Hello, Dr. Harshvardhan. How you are doing?
Oh, yes, thank you. Thank you, sir. Thank you, sir. I'm
Okay.
doing great. Let me switch my camera.
Oh,
Oh, sir.
okay. Hi, how are you?
Good, sir. Sir, my screen name is Raja Singh.
Okay. It's fine. It's fine. So it's my pleasure to introduce Dr. Harshvardhan Singh. He has done his BPT from MGM Medical College, Indore, and after this, he went to US to pursue his MS and PhD. Dr. Singh has been actively involved in developing and implementing novel clinically feasible methods to address the problem of age associated osteoporosis related fractures, and sarcopenia. In addition, he investigates musculoskeletal physiological changes in populations with low exercise tolerance. Dr. Singh has more than 10 publications in various international esteemed journals. His previous work has led to understanding of the functional and structural characteristics of musculoskeletal systems in different types of population, such as older adults with osteoporosis, individuals with spinal cord injuries, older adults with obesity, and children with cerebral palsy. Dr. Singh's current research is focused on utilizing muscle phasic contractions to induce mechanical load in a novel way to help address musculoskeletal deficits in older adults and the elderly. Dr. Harshvardhan Singh is currently working as assistant professor at the University of Alabama at Birmingham, USA. So I welcome Dr. Harshvardhan Singh, and the floor is yours. You can start the webinar.
Thank you, sir. Thank you for your kind introduction. And am I audible to you?
Yes,
Oh, great,
loud
great.
and clear.
Oh, great, great. I think Dr. Mathur sir was really, really kind in introducing me. Well, one very important thing I think was left out was I did my PT independent project under Dr. Mathur, and he really trained me hands-on, theoretical, applied PT. In fact, I would say that I learned to be passionate about PT with the grace of Dr. Mathur. So, Mathur sir, you have an indelible effect on my personality. So, thank you. So, let's get started. So, today we are going to talk about sarcopenia. So, let me share my screen. What do I want to share? Actually, I want to share that. Cancel. Nice. So, everyone can see the screen. Mathur sir, can you please confirm?
Yeah, just a minute.
Yeah, sure.
Yes,
Yes,
students,
sir, it
can
is
you
visible.
see the screen? Okay, yes.
Yes, yes.
Okay, I think
Great,
it's visible. So you may proceed.
great. Thank you. So, as you can see in the title, I have used the word urgent, and that's a very conscious decision to use the word urgent. Why there is an urgent need to assess, diagnose, and treat sarcopenia. But again, when you look at the title, there are multiple words here: assess, diagnose, treat. What do these words mean? What does sarcopenia mean? We will talk about all of this. So, overview my journey so far. So, Manthur sir has already done quite a part of that. I will do a little bit of that. We will delve into assessment, how that is different from diagnosis, and how assessment and diagnosis can inform treatment. Why should we be worried about sarcopenia? And finally, we will see what do we do to address sarcopenia. So this is my journey so far, coming from the original state of Bihar. I got my training at MGM in law. Dr. Mathur, Dr. Haribabu, they were my esteemed teachers. I learned a lot from them. I also worked as a consultant PT with Dr. Mathur clinic, a joint and spine clinic, and I learned a lot while working under him. And that was, I think, was the laying stone for me to get into research. So I got into Oklahoma, what you see here, and I did my master's under Dr. Deborah Berman, where I worked on osteoporosis and sarcopenia and how physical therapists can help screen individuals for the onset, who are at the onset of osteoporosis and sarcopenia. The more I worked with older people, the more I got interested to work with children. That's when I decided to move to Delaware. So I got my PhD from University of Delaware under Dr. Mark Lasky, which you see here in the middle. And my specific project was looking at the effect of botulinum toxin, which is also called as Botox injection, in the gastrocnemius muscles of children with cerebral palsy, and how that affects bone, muscle, bone marrow, fat in the muscle, fat in the bone, and how physical therapy can affect those outcomes. The more I studied about bone and muscle, I got interested in balance, and I joined the School of Medicine at University of Maryland, Baltimore. What you see, a very tiny red hair. I got trained by Dr. Mark Rogers, who is an esteemed physical therapist scientist, into looking at balance. And then I joined UAB. Well, there are lots of links here. Maybe I can share this PowerPoint with Hari Babu sir, and he can share these links with you. But overall, these links will tell you that the program at UAB, if you visit our department, we have multiple tabs here you can go into. You can see what programs we have. We have PhD program. We have Doctor in Physical Therapy program. Okay. And then I teach in both PhD and DPT programs. You can get to know about the faculty, and currently we are ranked number 13 in the ranking for the PT program. So we are the 13th best program in the country. So what is assessment? Well, assessment is an evaluation made by a healthcare provider to make an informed decision on whether or not to provide service, and if yes, what approach to take. Well, that's a classical definition of assessment. But how do you know, like you are doing assessment, and what are some examples of assessment? So let me minimize my screen and let me go to the chat box. So in the chat box, can anyone mention some of the assessment measures that you do on a daily basis? That would be helpful for the discussion and to understand.
Yes, students can answer. Anyone would like to answer? Deep?
Yeah, no, we are not, I'm not going to judge you, and it's all good. We are colleagues. Actually, I'm really blessed that I have Gauri ma'am here in the audience, who I have worked with. I think I also saw Lulu's name. And you are also my colleague, sooner or later. We all are colleagues. So it's just a discussion. Sensory and motor assessment. That was a good one. But that would fall more under the family of sensory and motor assessment. I was more concerned about what exact assessment you would do. And let's just start with some real basic thing. A patient comes to your clinic, and what you would do is you take height. You're assessing height. You are assessing body mass. You can use that body mass and height to assess BMI. You can assess waist circumference. You assess blood pressure. You take vitals. That's a very critical assessment of your patients. So these are assessment techniques and tools at your hand. But how do these assessments help to progress your treatment strategy or to progress to diagnosis? So, for example, a patient comes to you and the patient has an ankle sprain and you start assessing. So, what would you assess? Maybe you would like to assess range of movement. You would like to assess if there is a pain on palpation. So, these are some of the assessment techniques. And those assessment techniques will help you to decipher what the diagnosis could be. Assessment is not that hard. Um, Again, it's my personal opinion. What is really hard is diagnosis. It is rightly said that a correct diagnosis is the job half done. So let's move to the slide again. So moving on to assessment can provide vital and lots of different types of information. Now, as a PT, it's our job to connect all these dots, connect all these vital information, all these different types of information to come up with a story. And that story is our diagnosis. So what is diagnosis? Diagnosis is the identification and naming. I'm sorry, could you please, hey, Mathur sir, could you please confirm if you can see the screen?
Yeah, I think we can see the screen.
Yes, sir, it is visible.
Okay,
Yes,
great.
but
I had minimized the screen, so I was not sure. Thanks. So what is diagnosis? Diagnosis is the identification and naming of a disease, illness, or condition. Now, a disease is a disease as long as a disease is coded under medical coding definitions. If a condition has not been coded or is not coded under medical coding booklet, then it's not a disease. It is just a condition. So diagnosis could be of a disease, could be of a condition, could be of an illness. And diagnosis is indeed the hardest part of medicine. So if we have to contrast assessment versus diagnosis versus treatment, they are quite different. Assessments and diagnosis, right from the word application to the eventual clinical outcome, they give you different endpoints. Assessment, a good assessment can inform a probability of of a correct diagnosis, and a correct diagnosis can help with coming up with the correct treatment. And what is treatment? It is the attention, it is the medical attention given to a sick or injured person or animal. I'm assuming that you all know the difference between signs and symptoms because that is a critical part of assessment. While one is subjective, the other is objective. Patient can tell you that I have pain, but it's you, the physical therapist, who will assess if there is a swelling associated with the pain or if there are any other specific physiological measures which are associated with pain. So why did we talk about this? Sarcopenia is a interesting disease. And why interesting? Because it's not quite long ago that sarcopenia was officially recognized as a disease. Previously, it was said that muscle mass is lost, you have low muscle mass. But there was not a name that, hey, you have a disease. And the disease is the loss of muscle mass. The disease is you cannot perform to the best of your ability because you have lower muscle mass. So there has been a lot of debate and thankfully a lot of research and debate and clinical and clinicians. All the data helped to classify sarcopenia as a disease. So it started with the idea of loss of muscle mass. You see the word RSMI. The full form of that word is Relative Skeletal Muscle Mass Index. So what is RSMI? Based on the X-ray images, specifically DEXA, it's a scanning technique for body composition and bone density. You get the values of muscle mass in your upper limbs and lower limbs. You add the upper limb and the lower limb muscle mass, and then you divide the product by height squared in meters. What you get is the index of muscle mass. There are specific cutoffs. In male, if it is less than 7.26, and women, if it is less than 5.45, someone has a sarcopenia. So it has a specific cutoffs. But what was getting recognized that these cutoffs were not consistent for different people, meaning people who were not Caucasians or who were not whites, they had a different cutoff. They were not showing the symptoms of sarcopenia at these cutoffs, while some other people, some other races, they were showing symptoms at a higher cutoff. So RSMI fell out of favor. Then the European countries, they met together and they decided we've got to do something. And then, after years of consultation, the European Working Group on Sarcopenia, they came up with a specific cutoffs. If you have a low muscle mass, then a specific cutoff. If you have a low muscle strength, then a specific cutoff. Or physical performance, specifically your walking speed, below a specific cutoff, I will diagnose you as sarcopenia. In the US, Center for Disease Control, CDC, recognizes sarcopenia as a medical condition. So you can also, a PT can work on sarcopenia and rehab sarcopenia. These are some images that will show you the gravity of the situation. So just contrast the upper panel versus the lower panel image. And what you see as the bright area is fat, and the opaque area is muscle. Within the muscle, there is a small circular white area, a bright area, that's your bone. So you can easily contrast the upper panel, which has a lot of fat, not only outside the muscle, but inside the muscle. It's like fat is attacking the muscle and is trying to infiltrate in the muscle. Versus in a young adult, you can see that it looks like a nice, nicely formed, dense muscle surrounded by a decent layer of fat. So this you can contrast that how aging can affect your muscle mass. But that's the physiological thing. Has it got to do anything with how I perform? We always have to remember, muscle is an endocrine organ. Muscle does not only help us move. Muscle helps with secretion of various hormones. Muscle helps with uptake of glucose. Muscle helps with immunity. Muscle is a storehouse of amino acids. So when we are not eating well and body needs protein, muscle comes to the rescue. So muscle is wearing multiple hats. We should not think muscles only as your job is to move me. Your job is to lift weight. Your job is to lower down a weight. Muscle has multiple roles. And right on the next screen, what you see is young versus old histological picture of a muscle fiber. What I want to appreciate is all the red colored voxels are the voxels for your type 1 muscle fiber. The ones which are not red represent type 2. So when you look and compare the size of type 2 in young versus type 2 in old, you can see that the size of type 2 muscle fibers in old is drastically reduced. There is not much effect on type 1 though. And that's one of the things that we know about sarcopenia, that with aging, the muscle mass that you see in this MR image, that's mainly dictated by the loss of type 2 muscle fibers. As we all know, type 2 is important. Type 2 has a specific roles than type 1. It can help you move fast. It can help generate power. It can help generate greater torque at a greater speed. So a specific type 2 muscle fiber loss should lead you to think, how a specific loss of type 2 fiber can affect the specific loss of function associated with type 2 fiber as you grow old. So these are some of the cutoffs which are used to assess and diagnose sarcopenia. So you want to see low muscle strength, low muscle quality, low physical performance, and you have cutoff points here under table 3. For the lowest strength, you do a typical chair stand test and the grip strength. The grip strength is the hand grip strength. You use a hand dynamometer, and then you can use a hand grip strength. If it is less than 27 kg for men and 16 for women, that's sarcopenia. Chair stand. If someone is taking greater than 15 seconds for 5 chair stand, sit to stand, that is indicating the presence of muscle mass loss, sarcopenia. So what is the cutoff point for quantity? This is the ASM, meaning appendicular skeletal muscle mass, which is just what I described before. You need to add the muscle mass of your upper extremities and lower extremities. So if that is less than 20 kg for men, it's sarcopenic. 15 for women. Similarly, the ASM by height squared. The revised guidelines are if it is less than 7 in men and less than 5.5 in women, that's a case for sarcopenia. So what about functional performance? If the walking speed is less than 0.8 meter per second, less than equal to, that's again proves that you have someone who has sarcopenia in your clinic. You can also do other clinical tests like short physical performance battery. I will not go into the details of SPPB. It's readily available on internet. Goralnik from Baltimore, he developed this tool. And I personally have found this tool to be very, very effective in assessing as a prognostic tool, as a diagnostic tool to assess the different types of muscle pathology in older adults. So if on SPPB, you get less than equal to 8 point in timed up and go, if your patient takes greater than 20 seconds, so timed up and go is a specific task where you have a chair with armrest. You tell your patient, hey, you are sitting in your living room. That's what you have to feel. I want you to get up. You see this line, you start walking from this line, walk up to the other line, which is 3 meters far. You turn around, come back, and sit like you would sit on your room. The total time taken, if it is greater than 20 seconds, that's indicative of sarcopenia. And the last one is 400-meter walk test. Remember, it's a walk test. Sometimes when you ask your patient for these tests, they want to look good and they may start to walk fast. They may start to run slowly, actually. That's where a good physical therapist will make sure that the test is testing what it is made for. So the 400-meter walk test, the non-completion greater than 6 minutes, that's again displaying that you may have someone with sarcopenia. So if we look at this screen, the grip strength values, 27 kilogram for men, 16 for women. How was that decided? So what happened in Europe? They collected grip strength across the life course. Right from 0 to 100 years, people started coming to the clinics. They combined all data of hand grip strength. They found out what the normal was. So when the normal was known, the abnormal was calculated. Now, this is what we miss, I believe, in the Indian population. These values may be specific to the population of Europe. Currently, we lack data. There is no data on what is the normal progression of hand grip strength across the lifespan in Indian population. And this is a project that I would like to see. I mean, I would like to see that data where we can come up with a specific cutoff for the Indian population. So if any of you are looking for a project, this could be a nice project. Patients will come to your clinic, start assessing typical tests and getting normative data. Plot it and see what's the typical. How do you know what is abnormal? Once you know what is normal, you calculate what is the two standard deviation. And that will help you to know what value is abnormal, what value is normal. I hope that makes sense. So what exactly causes sarcopenia? And this is a figure from one of our papers that we published in Journal of Obesity. Lots of factors. But what we need to know, the four most important factors: the satellite cells of muscle, which are responsible for making new muscle cells, they become inactive. Oxidative stress starts to build up. It starts to take its toll. And as a result of oxidative stress, lots of reactive oxygen species, we have, that has actually a lot of adverse effects on muscle physiology. They start to accumulate. And all of these actually can be related to chronic inflammation. And all of these can lead to loss of motor units. As you can see in the figure, all of these causes of sarcopenia are interrelated. Oxidative stress can cause inflammation. Inflammation can cause oxidative stress. These both changes can cause cell death. Cell death can lead to DNA fragmentation. And DNA fragmentation can lead to death of motor units. Death of motor units can lead to loss of muscle fibers. And that's how, over time, a chronic inflammation can lead to loss of muscle mass. When I look at this figure, actually, I see aging as a perfect model which fits this. With aging, we build on inflammation. A chronic inflammatory state is pretty common with aging. And once you have inflammation, a chronic inflammation, that can lead to this cascade, which can lead to sarcopenia. So why should we be worried about sarcopenia? Well, this is a graph from the Ministry of Statistics, Government of India. And on the y-axis, you see population in millions. And on the x-axis, you have different decades, 61 to 71 through 2011. I want you to focus on the green line. And what you can see is that the population aged 60 years and above, they are rising up. In fact, I read somewhere that a silver tsunami is coming up in Asia, including India. And by silver tsunami, they mean individuals with white hair. Now, what gets interesting in this graph is that if you look at 2001 and 2011, the slope is really high. And this was very different from previous decades when the largest percentage of increase was seen in the elderly population in the last 10 years. This is further shown in this another graph, again, Ministry of Statistics, Government of India. And you can say that the percentage increase from 2001 to 2011 was almost 36% in the elderly, while the total population actually went down by 17%. So if you take the ratio, This is higher than 35%. So get ready to treat lots of older adults in future. Why should we be worried about sarcopenia? Because sarcopenia is not only just loss of muscle mass. It can have multiple adverse effects. And this is an algorithm that we think can explain the major effects of sarcopenia. Sarcopenia can lead to loss of muscle strength, loss of muscle power, loss of muscle endurance. Loss of strength can precipitate difficulty with weight-bearing tasks. Now, these weight-bearing tasks are your tasks of daily living. That can lead to a reduction in physical activity. Decreased endurance can lead to decreased physical activity. Decreased power can lead to loss of balance, which can increase risk of falls. And if you talk to an older adult who has balance issue or who has fallen before, they become afraid of walking. They become afraid of walking fast. What if I fall? So decreased power can also lead to decreased physical activity. That can lead to decreased energy expenditure, which can lead to weight gain. The weight gain itself can reperpetuate this cycle, and weight gain can lead to decreased physical activity. So it becomes a vicious cycle. If you don't address sarcopenia, it can lead to different diseases. Sarcopenia can lead to obesity. Sarcopenia can lead to osteoporosis because now you are not loading bone with enough of mechanical loading via physical activity. So individuals with a greater degree of sarcopenia can also have obesity, can also have osteoporosis, or obesity and osteoporosis individuals can have sarcopenia. Are we clear so far? Are we clear so far? Yes, sir. Good. Thank you. Thank you, Kenny. So the role of nutrition in sarcopenia, that's another very important, a critical role that nutrition plays. When you are in a fed state, amino acids, glucose, and lipid, they all interplay with each other. And body is a great machine. It decides where to send amino acids, where to send glucose, where to send lipids. It's a good fed state. So what would happen if it is a malnourished state? In a malnourished state, the skeletal muscle, which is the storehouse of amino acids, that becomes the fuel. And that starts to supply energy for tissue structure, for organ, for immune responses, skin integrity, neural function. So you start to lose muscle. And with malnourishment, we don't mean only the decreased caloric intake, which is very common as you grow older. But what I really mean is the decreased protein intake. So how much protein intake do we need? Again, depending on the state of body, it can vary. But typically, for an older adult who may have muscle mass loss, you start with 0.8 to 1 gram of protein per kilogram of body mass. And that gives you a good starting point. But again, when you are suggesting any nutritional advice, you need to make sure that the patient can readily take that. There should be a good adherence, and patient is medically cleared for this nutritional advice. So what can we do to prevent sarcopenia? We can maximize gains in youth to minimize loss in old. And on this graph, on the x-axis, you have age. On the y-axis, you have strength, muscle strength. And what you see here, that once the muscle strength peaks during early life, around 2025, it starts to go down around age 50, which is around here. And then, if it is not addressed, it keeps going down, where at some point in older life, it can go below the threshold of physical performance, still not addressed, someone can become disabled actually. And I have seen individuals who were not very active, they got into the vicious cycle, decreased physical activity due to decreased muscle mass loss, muscle strength, that led to increased obesity, further decreased physical performance. Uh, it was almost a disability. So this is very, very important that we start to address this problem in youth to delay the onset in old. Remember, loss of 10% of muscle mass can lead to increased risk of infection. 20% can lead to decreased healing of tissues, of bones. 30%. Loss of lean body mass up to 30% can have some severe drastic effects. Inability to heal, pressure ulcers, difficulty sitting, and a 40% decrease in muscle mass. Uh, well, now you are at increased risk of mortality. So this is very important. Now, when I look at this graph, I start to think about post-COVID rehab. COVID has led to lots of immobility period in older adults specifically, and that immobility period can lead to some severe loss of muscle mass. So even though a patient could have recovered from COVID infection per se, the residual effects on the loss of muscle mass may persist. So I see a huge gap where physical therapists can play a major role in addressing the needs of this population. This will also need that we work with MDs, with clinicians, and that's where the conversation begins. Currently, we are in a world where we don't work by ourselves. We have to talk to other healthcare professionals. We talk to nurses, we talk to MDs, we talk to occupational therapists, a speech therapist. So for an intelligent talk, we need to know some of these data so that we can show this data to these people and say, hey, physical therapy is an urgent need for your population, for your patient. And I have all the tools to assess, diagnose, and treat the loss of muscle mass, strength, and function performance, which is sarcopenia, in your patients. So this is where I think we also have to create awareness in other healthcare professionals and also in the public that you may have recovered from a typical bedridden condition, but you may not have recovered completely. Again, when you are looking at sarcopenia, I don't want you to focus only on aging and malnutrition. Well, there are hosts of multiple factors. Aging, disease, presence of comorbid conditions, concomitant disease, inactivity, just the lifestyle of your patient, the nutritional status, all these factors could interact and may be causing sarcopenia. So when you treat sarcopenia, what cause you are looking at? Are you going to treat aging? Are you going to treat disease? Are you going to treat inactivity or nutrition? So you have to come up with an algorithm, a treatment algorithm, where you can identify and rate what factor has the most weightage for sarcopenia and what factor has the least weightage. And this will help you to design a treatment algorithm which can work on all the factors at the same time, focusing majorly on the main factors. For an example, aging can interact with illness. I need some water. Well, aging can interact with illness, malnutrition risk, and all these interactions can lead to muscle atrophy, low force generation, impaired contraction ability. This is just an example of how aging can interact with a disease, which can interact with malnutrition, which can interact with inactivity. So this is what I was talking about. If you don't address sarcopenia, and if you look at the factors which cause sarcopenia, all of these factors are the same factors which can cause osteoporosis or obesity. So don't be surprised if in a patient with obesity, you see sarcopenia. Or if in a patient with osteoporosis, you see obesity and sarcopenia, or vice versa. And this is a conceptual model where bone, fat, and muscle, they all talk to each other. And fat says to muscle, hey, I'm getting bigger. Muscle will say, okay, if you're getting bigger, I will get smaller. And bone will say, hey, muscle, you are my companion. If you get smaller, I will come with you. I will also get smaller. So this is how they crosstalk. And the weightage of fat, if not controlled, can affect how muscle and bone talk. So these, as much as we think that sarcopenia is a muscle related condition, we have to keep thinking, well, muscle is talking to fat. I perform this treatment on my patient. I move the muscle. I tax the muscle. This muscle is going to talk to fat. This muscle is going to talk to fat. Hey, you know what? I was just exercised. So maybe I need to get stronger so that I can sustain this load. And then fat would say, okay, you better grow. I will take my own corner. So they all are talking to each other. Remember, whenever you are treating a patient and working on these tissues. So is there an algorithm that we could follow to treat sarcopenia along with assessment and diagnosis? Well, I believe there is an algorithm for everything. And I think we use algorithm for everything. Yeah, even if I have to do a silly activity, there is an algorithm that decides if I will do that or if I don't. So this is FACS. Again, FACS was proposed by the European Union. And FACS stands for Find Cases, Assess, Confirm, which stands for diagnosis, and then severity. You need to know how severe the condition is. And you can follow this flowchart. You can find cases where you have a clinical suspicion. My patient has not been very active recently. Could that be due to sarcopenia? Let me assess. You start assessing muscle strength test that we talked about. If it is normal, you get, maybe that's not the condition. Maybe there are some other reasons for lower physical performance. But if you find lower muscle strength, you move forward. Maybe there is sarcopenia. Let me confirm that. Then you can refer that patient for DEXA scanning to a physician and just ask, I want to know the muscle quality or muscle quantity. You can calculate appendicular skeletal muscle mass. That will help you to know if the cutoff is below or above the threshold for diagnosing sarcopenia. And once it is confirmed, you can assess how severe the condition is of my patient. And you can perform different physical performance that will give you some idea of how much you can tax your patient when you are treating sarcopenia. So what could be some of the treatment techniques? Muscle response to load. So physical activity, especially resistance training, that stimulates protein synthesis. But don't forget about nutrition. When you are taxing the muscle, you need to make sure that the muscle has proper fuel to replenish the work that it has done, to make sure that it can take your load. So high protein diets, and specifically there is a metabolite, leucine metabolite, and you can find it in various energy drinks actually. They work well together with exercise to help treat sarcopenia. But is resistance training the only tool in our hands? Well, if you look at the other figure, aerobic also can help indirectly to slow the rate of sarcopenia. Aerobic training can decrease inflammation and can decrease oxidative stress. So these two, if you remember, are two causative factors for sarcopenia. While resistance training does a hypertrophic signaling, aerobics can work on oxidative stress, and that can further help slow the rate of sarcopenia. Patient feels better regarding his strength. You have created a condition for your patient to be more physically active. Patient is more physically active. The patient is creating condition not to gain weight and keep the muscle and the bone loaded. So overall, it's working. But now the question comes, how many times should I prescribe my patient to do exercise? Should it be 2 times per day? Should it be 1 time per day? Should it be 5 days per week? So these are lots of combinations that you will need to work upon. What is generally recommended with a typical patient of sarcopenia, and what we have found is that 2 days of resistance training and 1 day of aerobic training really works great. Even if you do 1 day of resistance training and 1 day of aerobic, 40 minutes each, that can still work out as long as the nutritional component is good and you have a home exercise program to keep the body active for your patient. So you don't need to exercise 2 times per day or 5 days per week. A frequency as low as 2 days per week to 3 days per week has been shown to affect sarcopenia really positive. So these are some of the techniques that are in our hands. Now, when I say resistance training and aerobic, those are pretty big terms. It's like I'm looking at a building from a 9,000 foot. So let me go deep. Let me go and see what the woods are. Let me look from a 2 foot view. And that's where the coexisting conditions of your patient, the enjoyment quotient of your patient, the personality of your patient, all of these factors, the adherence, all of these factors will dictate what type of resistance training, what type of aerobic training you can prescribe. Within resistance training, do you want to do the typical concentric focused, or do you want to do the eccentric focused? Some of the research really coming up fresh off the shelf is showing that eccentric biased training can really accelerate in the acute stage of sarcopenia rehab, while in the chronic stage of rehab, concentric bias training can help. There is a caveat though. When you do eccentric bias training, that can lead to muscle soreness, that can lead to low adherence. Patient will drop out. So do you still do that? Yes, but with another technique. So with eccentric bias training, there is a technique called repeated bout effect. You want to use the repeated bout effect, which is exercising eccentric biased exercises at a typical low intensity, which is 30% to 40% of your maximum concentric. And that makes sure that once you reach the target of 50% to 60% of eccentric load, it is not creating soreness that can hamper the performance of daily activities. So eccentric biased, concentric biased, closed chain, open kinetic chain. All of these questions, weight bearing, free weights, all of these questions will be dictated by the fitness and by the physical condition of your patient. So what is the take-home message? The take-home message is sarcopenia is a disease. It's a newly coined disease, so not many people are aware that sarcopenia is not just a term, but it's officially it's a disease. It needs to be treated. The second take-home message is PTs are well placed to recommend an algorithm where we can suspect someone, we can assess, diagnose, and treat. If we cannot diagnose, we can help with diagnosis. So we can work in team with MDs, with other clinical clinicians. And once we have the algorithm, we have to make sure that we create an awareness, some of the cutoff points which are used to classify sarcopenia. And then the last take-home message is how you can creatively use the aerobic plus resistance training within 2 to 3 days per week to help rehabilitate your patient and gain back his quality of life. So these are some of the references. Feel free to let Hari Babu, Dr. Hari Babu. Hari Babu said no. If you need these articles, I will be more than happy to share these articles with you all. And I like this quote, I have no special talents. It's the curiosity. And you can see a curious child here. He is my 1-year-old son, Kavi. So I think that brings to the end of my presentation. I'm open to questions.
Okay, thank you, Dr. Harshvardhan. Yes, students, you may ask question now. Yes, any questions? Please feel free to ask.
Oh, I see, sir, I see Lulwa is also here. Oh,
Yeah, she is there.
yeah, great. Yeah, I have very fond experience of working with her.
Okay, you can write your questions also in chat box if you would like. Okay, so I guess there is no question from the student side. Well,
Right.
Dr. Harshvardhan, I would like you to ask. I would like to ask you one question, that is regarding your experience with Botox. So,
Sure.
yeah. So, means how far it is useful for a cerebral palsy patient to decrease spasticity, especially
Yeah,
if child is less than 5 years of age. So, is there any gold standard for that, or
great,
what?
great, great. Uh,
What's the current update?
Great, great. So that's really a great question, sir. I have a couple more questions in the chat box. So first, let me address the Botox question. Well, sir, let me be very open. The first thing is, according to the data, and especially the Germans have done a lot of work in Botox and how that should be used in a child with CP. The prevailing data is suggesting that uh, if you can manage it non-conservatively, that should be the way to go. And there are specific physiological reasonings behind that. Very first reasoning, Botox interacts with some other vaccines. So what some people have found, in fact, these Germans, Dr. Degler, he has done some extensive work, which shows it's very solid evidence that children get a lot of vaccinations in their initial years. Those vaccinations interact with Botox and make it less effective. So not only you need multiple doses of Botox, but you also need higher doses of Botox. Now that has its own set of problem. The higher dose of Botox or the multiple doses of Botox will further regulate the immunogenicity. So it's like the more I eat, the more it is not going to benefit me. So first of all, Botox has very limited use when it comes to treatment of spasticity. It is mainly used for. The second point is up to 10 to 12 years when the body, and this was the opinion of Dr. Freeman Miller, who is now retired, but he's considered one of the authority on cerebral palsy. So Dr. Miller, and I was fortunate enough to work with him at Delaware. So Dr. Miller used to say that growth is the best medicine, Harsh. And if you give the proper environment and load to the muscle and bone, they will react positively. So how you load the muscle can become very critical for a child with CP. Now, again, it's not like Botox is all bad. But again, one more point. What we found that children who were given Botox, the bone was getting not only weaker, but also small in diameter versus children with CP who were treated by physical therapists, but not with Botox. So that was a very interesting observation that we noted, that Botox somehow is leading to the loss of bone, and you don't want that in a child. So these are some of the negative aspects. The positive aspects of Botox, well, it can help to block the acetylcholine from acting. So it can help to release the spasm of the muscles. That's the problem because it blocks the acetylcholine action. The action potential cannot propagate. So when I try to voluntarily activate the muscle, it won't because there is no propagation of action potential. So the collaterals, they will fire up the collateral nerve endings. That may help. So, I mean, I would say the word is divided. If you talk to a physician, he will or she will have some other opinion. If you talk to a physician who has done talks but has no conflict of interest, that physician may have another opinion. My opinion would be if you can treat spasticity with mechanical loading with physical therapy, that's much more beneficial than Botox by itself. Did I answer your question, sir?
Yes, yes, sure, sure.
Okay.
You did. Okay, so we have a question from a student. She's asking, sir, is there any specific FITT based regime for sarcopenia?
Yeah. So that is a good question, Himani. And the problem with coming up with a specific fit guidelines or fit based regimen for sarcopenia is that sarcopenia typically coexists with lots of other conditions. For example, you are working with a patient with diabetes, and that patient may have sarcopenia because of the complications of diabetes. You may be working with a patient with obesity, that may have sarcopenia. Osteoporosis may have sarcopenia. In fact, you may be working with a patient who is recovering from COVID, and that patient also may have sarcopenia because of immobility and inflammatory of COVID. So it's not one size fits all. You have to be specific based on patient's coexisting conditions. What is known is that you want to load the muscle via both the techniques, aerobic, resistance, and at the same time, 2 to 3 days, 40 minutes per day should work out. Now, how you design the 40 minutes is you. So, did I answer your question, Himani?
Himani is there? Okay, would you like to ask? Okay.
Great.
So, yes,
Yes, sir.
yeah. So, Mr. Parth Kumar would like to ask you, is sarcopenia possible in child?
Yeah. And this is again a very, very question which is dear to my heart. The use of terms. You know what, Parth? Sometime you may talk to a healthcare provider who may use the terms like sarcopenia or osteoporosis in pediatric population. So let me, first of all, it is not possible that sarcopenia would exist in child. And why is that? Sarcopenia is loss, okay? Loss of mass, muscle mass, loss of strength, loss of physical performance. To loss, you have to gain first. If you have not gained, how can you lose? How can you lose? So, childhood is a period when there is a lot of gaining going on. So, the use of term like sarcopenia, osteoporosis, these terms, they do not sound good to my ears because it's a growth period. But what if there is lower muscle mass or lower bone density or lower bone strength in a child? I would say it is underdeveloped. Underdeveloped muscle, underdeveloped bone. That's much more legitimate to use. Uh, did that make sense, Parth?
Okay, sir. Next question is from Deep. He's asking about is low level of testosterone also one of the cause of sarcopenia?
That's a good question, Deep. In fact, these were some questions, not exact this question, but these type of questions which really honed my interest in research. So low levels of testosterone. So when we talk about testosterone, there are multiple types of testosterone. One, which is freely moving in blood, and one testosterone, which is bound. So the freely moving testosterone, not of use. The bound testosterone, yes, that's of use. The testosterone that bounds to muscle. Yes, testosterone is important for muscle growth. Growth hormone is also important for muscle growth. But is it a cause of loss of muscle mass? Um, Maybe that could be the case. I'm not sure if that is a certainty with everyone, but yes, maybe in few individuals, low level of testosterone could be associated with sarcopenia. But does this association mean it is a cause? Well, I'm not sure about that.
Okay, I think our time is limited,
Great.
so there are no more questions. So thank you, Dr. Harshvardhan, and it was indeed a very informative session. Now I would like to ask Dr. Haribabu to say a few words. Dr. Haribabu, over to you.
Hello, Harsh.
Hello, sir.
How are you?
I'm doing fine, sir, and thank you. Thank you for this opportunity. Yeah,
Okay.
I really loved these
It,
questions.
it was it was good presentation, and so on behalf of PP Savani University and School of Physiotherapy, I would like to thank you for the enlightening words which and knowledge you have shared on the topic sarcopenia. And today's webinar was full of knowledge and gave insights into the topic and also revealed some interesting facts about the sarcopenia. I'm sure the precious knowledge given by you to our students will help in their studies. And I would like to thank all the faculties and students who had joined the session and got benefited. And my heartfelt thanks to the MGM students and other institute who have actively participated in this webinar. And once again, I thank you for your wonderful time given to us. Thank you.
Oh, thank you, sir. It's the feeling is mutual, and sir, there is a slok in Sanskrit which means a teacher is God. So I would say that I was really fortunate that I had you and Dr. Mathur and Mathur sir as my teachers. Yeah. So I was really
So,
fortunate.
Thank you.
okay, so thank you, Dr. Harshvardhan,
Thank you, sir.
and we would look forward for such informative sessions, more in coming year.
Cool.
And particularly, I would like you to, maybe after a month or two, if you can, if we can have a webinar on again the scope of, physiotherapists in USA and how they should go about it, because it's, many students who are doing internship in our college, they would like to, pursue higher studies in USA and they want to work there. So maybe in a month or two, whenever you have a free time, I would like you to, conduct a small session for our students, so they would
Cool.
really benefit from them.
Cool. Thank you, sir. Sure, I will. Thank you, sir.
Okay.
Okay.
Thank you,
Nice
Dr.
day.
Harshvardhan. Thank you all.
Thank
So
you.
we are closing. Okay. Bye bye.
Thank you, everyone. Thank you, everyone, for joining. It was great. Yeah.